Hi, this is Leanne Kaiser, and this is current event number 6 for MHA 575. This one is about the primary care shortage. It was an article that was published on February 22nd of this year, how state policies are worsening our doctor shortage. So, America's healthcare crisis, the shortage of primary care providers. So, one of the most serious problems facing the healthcare professions and the public's health in the United States is the shortage of primary care or general care doctors. Currently, approximately 82,867,940 Americans live in what is considered a health professional shortage area. We'll talk about that in just a moment. But this is part of a huge crisis in the United States, is the lack of primary care providers. So this graph, is this a health professional shortage area or a medically underserved area / population? So I'm going to talk quite a bit about what these areas are and what they're not. So what is a health professional shortage area? So this can be a geographic area, a population, or facilities. These areas have shortages of primary, dental, or mental health care providers. So a geographic HPSA, and that's what it's called, a HPSA, a shortage of providers for an entire group of people with a defined geographic area. What is the population HPSA? A shortage of providers in a specific group of people, defined geographic area, so meaning low income or, for example, migrant workers. What is a facility HPSA? Public or non-profit private medical facilities. They serve a population or geographic area with a shortage of providers. So, or correctional facility HPSA would be a medium or maximum security federal or state correctional institution, or a youth detention facility with a shortage of providers. A state or county mental hospital, so a state or county hospital with a shortage of mental health providers. So automatic facility HPSAs, facilities that automatically are designated as a HPSA based on statute or through regulation is a federally qualified health center, and that's what SIU Family Medicine that I work for is a federally qualified health center, or an FQHC. They provide primary care to an area or group of people in need. They offer a sliding fee scale. They provide complete services and have an ongoing quality assurance program. They also have a governing board of directors. So they receive grants under the Health Center Program, Section 330. So some other things that are work in health professional shortage areas are things like FQHC lookalikes. So these are community-based healthcare organizations. They don't meet the requirements of a actual HRSA health center, but they do a lot of the same services. Things like Indian health facilities, IHS and tribal hospitals, dual-funded community health centers and tribal clinics, and then also a rural health clinic, which is actually what the SIU Center for Family Medicine used to be, was a certified rural health clinic, and they actually changed over to an FQHC. So what is a medically underserved area or population? So a medically underserved area or population identify geographic areas and populations that lack access to primary care services. These designations help establish health maintenance organizations or community health centers. So MUAs have a shortage of primary care health services with geographic areas such as a whole county, a neighborhood of counties, a group of urban census tracts, or a group of county or civil divisions. Whereas MUPs, medically underserved populations, have a shortage of primary health services for a specific population or a subset over a geographic area. These groups face economic, cultural, or language barriers to healthcare. So some examples would be people experiencing homelessness, people who are of low income, people who are eligible for Medicaid, Native Americans, or migrant farm workers. So, when we talk about a HPSA or a MUA or MUP, we talk about these areas as being something that has been designated by the federal government as lacking services. So I think that's something to take out of this piece of that. So by 2033, there will be a shortfall of between 21,400 to 55,200 primary care physicians in the United States. So that is according to the Association of American Medical Colleges in the U.S. So huge numbers of projected shortfall of primary care physicians as a part of an overall projected physician shortage of between 54,100 to 139,000 of overall shortage. So, you know, it's a growing problem. It's a problem of concern that a primary care physicians you will not be able to access them nearly as easily as we do today. It's a problem today, and we know it's an existing problem, but it is a concern, a great concern for the future. So why is the primary care shortage getting worse? So there are many factors associated with why the primary care shortage is getting worse, and what we can do about it. So what's the reason for it, and where are we headed in it, and what is our American Medical Association planning to do about it? What is the government planning to do about it? And why are the issues there? So when we think about what's causing the shortage, we think about a couple of things here. So population growth and aging. So we talk about the baby boomers, and we talk about those folks being a part of the overall problem. We also think about the physicians that are currently practicing are reaching retirement age. So not only do we have an overabundance of population aging, but a lot of those providers that are currently providing those services are reaching physicians' retirement age too. A big factor in that is that medical students are not choosing primary care as their specialty. So not only do we have a lot of physicians retiring, but we don't have medical students replacing them in those primary care specialty areas. And then finally, state licensing restrictions that are certainly putting barriers to how primary care physicians can practice, which is certainly not helping anything. So population growing and aging continue to be one of the primary drivers for the increased need of primary care physicians. From 2018 to 2033, the U.S. population is projected to grow 10.4%, from 327 million to 361 million, with age 18 growing by 3.9%, but over 65 growing by 45.1% by 2033. So that 2033 mark is really where those baby boomers are starting to hit the elevated ages. So they're, 80 plus, 85 years old, and that's going to impact the number of primary care physicians we need with that elderly population. Another factor for the physician need is a large portion of the physician workforce nearing traditional retirement age. Excuse me. With nearly 2 of the 5 currently active physicians being 65 or older within the next decade. The primary care workforce faces an ever-growing crisis, partly due to the lack of medical students pursuing the primary care medicine services. So this comes into play with something I've talked about in a couple of the other portions that I've done, is the part of the increasing debt of medical students and the reimbursement for primary care services. So, they're coming out with a lot of debt, upwards of $150,000 debt currently. However, I discussed in one of my previous topics that having a current medical student, I think when we look at the statistics of what is right now with medical students, a lot of those medical students are probably going to come out with closer to $200,000 of debt. A lot of medical schools are upwards of $50,000 a year. That certainly doesn't cover their needs outside of their tuition. So, it's very common that a medical student come out with more than $200,000 debt these days. Having worked in resident education, I've seen when those residents get to our programs and them talking about, $200,000 and $300,000, $400,000 of medical education debt that they're trying to repay. So when they're looking at specialties and they talk about the income associated with specialties, and they're thinking about that $300,000 or $400,000 of debt that they have, and they're looking at what a primary care physician is going to make, it's really easy to see why they're steered toward those higher income portions of physician care. So when we think about primary care providers, we think about first contact care. We think about continuity of care. We think about comprehensive care. And then the concern for the overall patient rather than just one organ system. So they're thinking, a primary care is thinking about treating you as a patient from head to toe, not thinking about just your gastrointestinal area or just your lungs. So that's what we mean by that. So primary care has been described as the four pillars of care, like we talked about: first contact, continuity of care over time, comprehensiveness, concern for the entire patient over one organ system, as well as the coordination with the other parts of the health system. So they really are kind of seen, and I know this word is taboo because we think of the HMO piece of it, but they're seen as the gatekeeper of care. So they're really where you should start for 99.9% of your care. And then if a specialist is needed, they'll refer you out. This care, combined with the administrative burden associated with primary care providers from patients, insurers, policymakers, establish just a part of the primary care physician's duties. Primary care physicians, or generalists, include several categories of practitioners: family practice, also now known as family medicine, general internists, geriatricians, and general pediatricians. Primary care can also include nurse practitioners and physician's assistants, which have increased over the years and have lessened the burden of the primary care shortage. So we really are relying much heavier these days on PAs and nurse practitioners. Excuse me. Okay, so when we talk about medical school debt, I think this is what the average medical student feels like, is that they're carrying around this boulder, that they're pulling with this chain that they feel like they're literally never going to get anywhere with. As my daughter is sitting over here giggling, thinking, absolutely, I have a huge boulder behind me. Medical education costs grow, so do most students' debt. Sorry. More than 85% of medical students now graduate with outstanding loans. The average student indebtedness is $157,990, with nearly 80% of graduates owing at least $100,000. In contrast, just 2 decades ago, indebtedness averaged $27,000. So you see why the amount of debt is just growing just exponentially for these medical students. And these are statistics according to the AMA, their associations. Physicians' incomes have increased, but at a much slower rate during that same time frame, making it much more challenging to repay their educational loans more than ever before. So when they're thinking about what specialty they're going to pursue and they're thinking about those loans, it's very easy to understand why they're choosing those hot topics and high-paying professions. So this is a graph that shows by specialty the average income to be assumed for these positions. So the number one being orthopedic surgeons, with an average salary of $511,000 income per year. So $511,000, any way you look at it, $500,000. Plastic surgeons, $479,000. ENT, you see all of those surgical services up there, well over $400,000. And if you look at the bottom, you see pediatrics. So that's one of the primary care specialties we've been talking about. Sorry. At $232,000. Family medicine, just barely above that at $234,000. And these are averages. So in certain areas of the country, they won't reach this. So it's very obvious to see why they're choosing those high price, high income specialties like orthopedics and plastics and cardiology and radiology over primary care services. So the annual average salary for a primary care doctor is about $180,000. So this statistic shows that it's a little higher at 232, but all relative to areas, which in some cases is about one half or one third of a subspecialty. So as you can see with the 511, you're well below half of that salary. This is in part due to insurance reimbursement of primary care services. The insurance company's rationale behind this is it's easier to determine the worth by an objective measure if something can be counted or visualized, meaning using an instrument for a procedure rather than cognitive experience. So, primary care providers are pretty much doing diagnostic skills. And so that meaning those cognitive skills sets, so it's not nearly as easy to quantify for an insurance company. So this is a specialty service for our specialty organization for family medicine. So the American Board of Family Medicine. Since 1847, the AMA has lobbied that every state enforce its own medical licensing laws, with some federal oversight, even though licensing qualifications are generally dictated by their specialized organizations, such as the ABFM. They are practically identical from state to state. This consistency should make state-level licensure unnecessary. However, these boards have used these licensing requirements to collect over $100 million in certifications and testing fees to aspiring doctors. So there's a lot of money in the industry to have more state-level testing fees, licensing requirements, rather than there being one uniform United States medical license. So once again, we come back to money as to a barrier to this process. So, I think this graphic shows a lot of areas that a provider's being pulled in what they're doing on their day-to-day basis. So until recently, doctors were barred from practicing in states where they had not been licensed, not even for telehealth services. So when COVID-19 pandemic hit, state licensing limitations became apparent. Areas that were hit hard by COVID-19 were in desperate need of medical providers, physicians in particular. The temporary relaxation of cross-state licensing enabled some of those areas to better cope with the provider challenges. As a result of this successful experiment, even the AMA is now considering the thought of universal licensing in the United States. So this is just one more barrier to why there is a primary care shortage. So when you're thinking about a sensible licensing regimen, Utah has not only permanently opened its doors to doctors from other states, but has also implemented policies to speed up their licensing processes. In fact, Utah has been on the forefront of medical access for years, even allowing doctors licensed in Canada to practice within its borders since 2014. And the state has continued to build on these sensible policies. So they continue to open up their areas. They're willing to certify doctors in other countries, whereas a lot of foreign medical graduates have to do a lot of time in the United States before they're eligible for licensure. So I think there's opportunities here that have come from the pandemic that can allow us to ease our licensing burdens for these medical providers, especially through telehealth right now. You can provide telehealth to a patient that's not currently in your state, even though you may not be licensed in their state. So that's one of the things that have relaxed. So when we talk about this, ultimately this comes, down to money. The above factors for increasing debt of medical students and reimbursement of primary care services impact medical students' decisions as to what type of medicine they're seeking. They're trying not only to choose what they feel is the best fit for their medical education, but things like repaying medical school debt have a balance in both work and family, feeling respected and appreciated by not only their patients but their peers, but being paid appropriately for the work they do, are all impacting the rates at which students are choosing primary care. The state licensing issues further complicate the scenario. Practicing in more than one state needs to be revised to help the primary care shortage, especially in rural areas. For example, it would be reasonable for a primary care provider to practice in Southern Illinois, Kentucky, and Southeast Missouri. We're in an area where they can travel 45 minutes and be in another state. However, the barriers to licensing, costs, the additional paperwork prevent some from doing so. So that only adds to the additional shortages. We've had providers who have licenses in Missouri and Kentucky, but it is very cumbersome for them and expensive for them to do so. So according to the information that's being presented right now, the COVID pandemic has already been felt by Americans nationwide, according to the physician shortages. So, when people were reaching out for services during the pandemic, there was not enough supply for the demand that the pandemic was providing. So, to help address the physician shortages all around, a bipartisan Resident Physician Shortage Reduction Act in 2019 was introduced. So it would help provide 3,000 new residency spot positions each year over the next 5 years to help increase the numbers of physicians we can get into the pipeline. Now, that is not going to be instant because they spend anywhere from 3 to 6 or 7 years in residency, but this would help in the future. So the pandemic has shown an importance in investing in strong healthcare infrastructure to ensure access to care. The step that Congress has taken to assure adequate physician workforce, to end the freeze on federal funding for graduate medical education that has been in place since 1997, that limits the federal support for training physicians, is being looked at and hopefully will be lifted, and we can get more physicians providing care in the United States. So this physician shortage is a huge concern, and the lack of primary care is an even greater concern. And there are many ways that we can help provide additional primary care in the workforce. I think we have to look at medical education as a whole, the expense of medical education, the opportunities for residency programs that can provide additional services. We have to look at more opportunities for loan repayment for these individuals who are seeking primary care physicians. And positions in the industry. If we can provide more reimbursement of their education expenses, they're more likely to pursue these positions of primary care physicians. If we can help repayment, that's huge. And if we can also look at opportunities for actually rewarding patients to seek primary care services by rewarding those physicians treating those patients through generous reimbursement from the insurance companies. Stop reimbursing those high specialty areas so much greater than the primary care physician that may have been able to take care of that patient. So lots of aspects here in the primary care physician shortage to look at, and I think there's going to be many conversations about this over the next few years as a result of the pandemic. So more to come, obviously, on this topic. Here are the references I used for this presentation, as well as my experience in primary care myself. If you have any questions, please seek out one of my, either my email or by call. I'd be glad to discuss any questions that you have.